flexible, malleable, able to seek the supporting surface. Once you reach forefoot contact in normal gait, the axes juxtaposition, and the foot begins to supinate the rest of the way through gait, locking those bony structures up like a very rigid lever for propulsing body weight forward to the next step. Pretty nifty, huh? That's pretty amazing. The first 10 to 15% of gait is pronation. The rest of it is supination, the rest of the way through toe off. As the foot is doing that, the leg is doing this. So you've got rotation in and out in the leg as the foot is everting and inverting. And the hips are going through rotations. In normal gait, when that's happening, you can run, jump, leap, stand, work for long hours on those feet in a day. It's just incredible. When you're outside the normal parameters that we're talking about, it's a different story. So we talked about the pronating foot. A person who has an inverted foot which is fixed, which is called what? A varus deformity. That's a varus deformity, fixed internal bony position. If a person has an inherited heel that's inverted, and he strikes the ground inverted, and he goes to that point in gait there, but his weight is still to the outside, and now we were to supinate, what would happen? He'd fall. You can't do it. Not with an inherited tilt like that, where you can't get far enough to the ground to get the weight towards midline. The only option a hyperpronator has, a person who has a varus tilt, is he must continue to pronate in an effort to get that weight towards midline. You following me? So looking at my hand, it represents that. He's pronating all the way through contact gait. What happens with the axis? The axes have gone parallel and they stay parallel all the way through contact gait. So the foot is hypermobile on the ground. It flattens, it splays. The more severe the varus tilt is, the more the foot will flatten. So what do you see? Flat foot. When you see a flat foot, a person sometimes is rolled in, they're like that on his ankles. If you actually look to see what the subtator joint neutral position is, you might find a highly inverted tilt. They've just had to roll like crazy to get that weight towards midline of the body. So when you have a foot that is a hyperpronating foot, they work like all get out to get the weight midline, but by the time they've gone through toe off and never got there, you're still flat in a hyperpronating foot. In a foot where you have the inherited valgus position, then they are locked right from the get-go. Heel strike all the way through gait, they are locked. It's a hard hit. When you hit that ground with a supinated foot, it hits hard, and it goes all the way up the limb. You feel it in the ankle, the knee, the hip, the lower back, the neck, possibly get headaches in here. If you got that foot that is locked, it never goes through the unlocking, locking activity. So you can appreciate that what we're trying to decipher here is how can you detect where the prospective ulcer is going to occur in the type 2 diabetic who has neuropathy. You got two things you want to be aware of. Gait analysis. Have we got a willing volunteer to walk for us? Anybody be willing to walk back and forth? Thank you. So it's, I know your name and I can't think of it. Manuel, thank you. So Manuel, we'll have you walk up and down that way because we can see. So normally you have a patient take his shoes off, roll the handcuffs to about mid-calf, handcuff up to there so you hopefully see the knee. Sometimes you just can't get it over the knee, but you try. A thin sock is okay. It's even more preferable to be barefooted, but a thin sock is okay. So we'll do the best we can here. And then you want him walking away, not side to side in front of you. You can't see side to side. You want him walking back and forth. Let's have you come over here. Can you all see from that angle there? If you want to stand up and move over there. So we'll just have you walk back and forth. And you tell the patient, ignore your feet. Just don't think about them as you walk. So go ahead and walk right and roll and back and just keep on doing it. Okay, now, What do you see? Manuel's in your office and he's walking for you back and forth. You start at the shoulder. You see if there's any shoulder drop. You look down the spine. You look at the waistline. Is his waistline level? Is it horizontal on the transverse plane? You look at any obvious in-toe or out-toe, antalgic gait, anything that just doesn't look right. So now what can you tell me about Manuel's gait? What's that?
Left side is E2E.
Say it a little louder, so you can hear.
Left side is 2E.
In turning or out turning? Out turning on the left? Okay. Let's talk about upper torso down in the waist. Anything you see that's different there? He looks pretty healthy, pretty strong, pretty everything there is in place where it ought to be in the upper torso. Go down to the knee. Can you see anything relative to his knees? Oh. By the way, if a person hyperpronates, there's more shock in the limb. You'll see that jolt in the leg with hyperpronation. Looking at his feet, where does the weight fall on his feet? Anybody care to take a guess? Come on up this way, Manuel. Where is his feet weight? Stop for just a second. I see his weight falling about right in there. You feel most of your weight. Where is that? That's where his weight is. Where should the weight normally be? The second metatarsal plane goes on 70 to 75% of the body weight should be right there. That's where it's supposed to happen. So, if Manuel's weight is over through here, what does that tell you about his gait? Is he a hyperpronator or a supinator? Well, had a chance to watch him walk now. You'd like to see him slow down, right? So you can kind of put that together. So Manuel, rather than have you walk, turn around and face us this way. And I'm going to have you lift your feet up and down like a soldier march. Now I want to emphasize something. When you see a biomechanical fall, I'm here to tell you, we're mortal. We're mortal. And to have a tilt to the foot is very normal. We see it all the time. Bottom line is you got to watch for that diabetic foot. What makes have you come to a stop? And you see he stopped. If he were to stop and then place the foot elsewise, you do it over again because that changes it. But now, as Manuel stands there, you actually have captured his angle and base of gait, which is the way he places his feet when he walks. That's the way he walks. So if you look at Manuel, you can see a little bit more external position of this foot. See that? You see the angle between, or the base of gait there is a little more than 4 inches. It's probably about 5 inches, but not a long way off. So if you were to make any statement about what you see, what would you say to me that you've seen here in Manuel's gait? Does he pronate more than normal? Well, remember now comparing here what I'm talking about. The normal angle of the feet is how many degrees external to the sagittal plane? 10 degrees. Normal is 10. Normal base between the feet is about 2 to 4 inches. A bisection of the knee should go over the second metatarsal phalangeal joint. Now, if you can get that in your mind, you've got something you can really work with. That'll tell you a lot. So if you look at the bisection of Manuel's knee, I'm saying his bisection would go about like that. Would that correlate with your thinking? That's about where his bisection of his knee would go. It's about right there. Is that bisection of the knee internal or external to the longitudinal bisection of the foot? Is it medial or lateral? bisection. So you're looking, here's the kneecap is going to bisect about like that, and its foot is external to it. So this bisection of the knee is medial to the longitudinal axis of the foot. The knee axis is medial towards the midline to the longitudinal axis of the foot, which says on well hyperpronate. More pronation, and his weight is going to fall more to the lateral side of the foot. Now, in general terms, for the typical public, a person who hyperpronates will tend to have more fatigue in their legs. If they standing, man, I'm tired. I need to find a place to sit down. You ever experience that? Fatigue in legs and feet, sometimes discomfort in knees, hips, or lower back. That is because the muscles are not quite functioning in the normal position anatomically with complete balance. With a person who is diabetic and has neuropathy and can't feel his feet, where would you predict that the ulceration is going to occur? Lateral side, where that weight is being formed, because it's pressure point pressure that causes diabetic ulcers. Thank you. I appreciate that very much.